So I just wanted to say thank you to everyone for joining in for today's seminar presented by the Centre of Research Excellence for Prevention of Falls Injuries. And our topic for today is inpatient fall prevention. And I just wanted to start by acknowledging the traditional owners of the land from which I'm chairing this meeting today, the Kaurna people of the Adelaide Plains, and pay respect to their elders past and present. We acknowledge that their cultural heritage, beliefs and relationship with the land are of continuing importance to the Kaurna people living today. And we also extend that respect to other Aboriginal language groups and First Nations. So perhaps I'm going to give a short 10-minute introduction really with a recap of the evidence for preventing inpatient falls from the last Cochrane review for that setting. And then we've got a couple of speakers who will talk about their personal experience in research and being involved in falls prevention in hospital settings. So as a little bit of background, I think a lot of people in the community think when they're in hospital, they're safe from falls. There we go. But to give you an indication of the incident.
Oh, right.
Could everyone please mute their computer? Thank you. So as a bit of background of incidence rates of falls in hospital settings, in acute settings, we've got some large studies that give us an indication. A fairly standard rate of falls that often occurs is around about 6 falls per 1,000 patient days in acute settings. And in subacute settings, that can be higher. So in Australian rehabilitation or geriatric wards, that's probably around 10 or 11 falls per 1,000 bed days. But that can be as high as 17 or 18,000 bed days in really high risk settings. Now, because of this, a huge amount of money is spent in hospitals around the country on falls prevention strategies. And it's been estimated that nearly 600 million in falls prevention strategies is spent in Australian hospitals in a year. And this does include some strategies which lack evidence and are potentially ineffective. So it's worth recapping what intervention strategies there are evidence for. And to do that, I'm going to just come back and recap what the latest Cochrane review of falls prevention strategies in hospitals told us. And this was out in 2018, so there have been some new studies on that since then. But at that time, this Cochrane review found evidence that multifactorial interventions can prevent falls in hospital settings. Now, multifactorial interventions are multiple component interventions, so they don't deliver just one thing. You know, it might be exercise and mobility aids and education programs, a range of things, but they're not the same interventions delivered to every patient. They're delivered based on the individual risk profile of the patients in the hospital setting. Now, in the Cochrane review, there were 5 randomised controlled trials of multifactorial interventions with more than 44,000 participants across these trials, and they contributed data on the rate of falls, and a subset of these also provided data on risk of falling or the risk of any individual patient falling 1 or more times. And this review found that multifactorial interventions might reduce the rate of falls, and in particular in a subacute setting, you can see that the effect was stronger, and the evidence for this came from 2 studies. The evidence for risk of falling, so reducing patients to never falling at all, wasn't quite as strong, although it was still trending in that direction. For those who want to look at the data, this is the subgroup analysis of these trials of multifactorial interventions in hospitals. And here it's subdivided into acute settings, 1 trial here, a mixed setting, subacute and acute within the trials. And here we can see the subacute subgroup. And there's 2 trials that contribute to this data showing that multifactorial interventions can reduce falls in this setting. And so it's worth perhaps thinking a little more about what particular interventions were delivered in these trials. So the first was a trial by Terry Haynes in 2004, and they're both Australian trials, which is, great for the relevance for this group. And so this was conducted in 3 Australian wards, and the intervention program delivered falls risk alert cards, exercise and education program individually delivered by an OT, and hip protectors. In Amory Hill's more recent and larger trial in 8 rehab and geriatric wards, the program had individualised multimedia patient education delivered to patients with better cognition. And there was also staff training on patient uptake of falls prevention strategies and their individualised goals, feedback on whether patients were achieving those goals, and perceived barriers to the patients. So, for example, feedback that a patient couldn't always use their mobility aid to get to the bathroom because it wasn't left within reach, or something like that. And a subgroup analysis within this trial showed that there was an even stronger effect naturally within the subgroup that had higher cognition that received the intervention, but there was an effect on the ward overall, presumably partly that feedback through to staff having an effect. Within the Cochrane review, other interventions that were looked at, there was also low quality evidence that just providing education materials to the patients alone didn't have an effect. And the bar for the quality of evidence that you need to make clear statements in Cochrane reviews is very high. So within the Cochrane review, it said that it's unclear for quite a number of other intervention strategies, so exercise, medication review, vitamin D, environmental and social interventions. But I just thought I'd show you what data there is on these, even though the quality of the evidence isn't considered high enough to provide a clear statement within the Cochrane review. So here you can see there was a couple of trials on low beds and ID bracelets that didn't show a clear effect. Similar with bed alarms, there was a couple of trials of bed alarms which had no effect. And a number of trials with various organisational service model change interventions. And there was no effect of guideline implementation or simply fall prevention toolkit software. However, there was a small trial of orthogeriatric service for post-hip fracture care that did improve falls prevention in that particular group. And that result held up in a really small subgroup analysis of people with dementia. Within the review, there were also 2 trials of additional exercise versus the standard within a subacute setting, and that did reduce falls, although obviously it was a very small number of patients across those trials. Oh, that reduced the risk of falls. So concluding from the Cochrane review, multifactorial interventions which deliver a variety of different strategies, as opposed to those studies where we're looking at just one intervention alone, can reduce the rate of falls, particularly in a subacute setting. And both of the intervention trials that showed it worked included tailored patient education. Now, since there's generally, fairly limited information, it'll be great to hear from a couple of researchers and clinicians who've got some coalface experience doing falls prevention strategies. And we'll move to these speakers now, and perhaps if there's any questions on the Cochrane evidence, we'll hold that over to the end. So first up, we've got Petra Bierer. She's actually within the unit that I'm working in and Flinders Medical Centre. She's the acting co-director of the Division of Rehabilitation, Aged and Palliative Care at the Southern Adelaide Local Health Network. She's an advanced nursing director of the division and also the executive lead and chair in the clinical governance and partnering with consumers framework within this division. Thank you, Petra.
Thank you, Sue. I'm hoping that I'm going to get this, the IT okay. I'm used to Microsoft Teams, not Zoom. So can you hear me okay?
Yes, we can.
All right, I'm going to try my sharing of the screen. Fingers crossed. All right, so can you see my first screen that's got acknowledgement of country? And I just want to check as I go through that you can see. Can you see the second slide? Is that a new slide? Okay, perfect. All right, I'll get going. So thank you for inviting me. It's very exciting for me. Sue's already done the acknowledgement to country, and today I'm going to be talking about a program that we've implemented into our subacute rehabilitation services called Profits. And is it about making money or preventing falls? I just really wanted to say a big thank you for inviting me to present today. It's a very exciting opportunity for me to speak on behalf of my team about and to be able to share the learnings and improvement work that we've been working on for the last few years. And I'm not a researcher. I still want to be a clinician. I am a nurse fundamentally. I am sitting in the executive lead role at the moment, but I do have a very strong connection with the teams on the ground. I wanted to give a bit of a background about who I am and where I've come from. And Sue did allude to that I am an ICU nurse. I'm an ICU nurse for 30 years. That's where I was born and bred. So I've come from a very complex environment where they have critically ill patients, and that was everything I lived and breathed for 30 years, and I would never do it any differently. So it was very different for me to come into a new role that I'd applied for and was very and have loved since I've been in here. Around subacute services. So in intensive care units, we've got one-to-one nursing. Most of our patients are sedated and ventilated. We have minimal falls. Falls was always a risk, but very minimal. And it was a lot around pressure injury prevention and minimising harm in lots of other ways. I came to subacute services where I was exposed to patients who mobilise, take risks, and have lots of therapy. So it was a very, very different, and is a very different space. So I had a lot of learning for me to go on. And I just remember some of the, at the very beginning when I started in the division 5 years ago, going, meeting, introducing myself to all the clinicians and listening to handover. And there was always this thing around, and this person's at risk of falls, and this person, and this person. I was thinking, so everyone's at risk of falls? Someone must be at a higher risk of falls than another. And it was challenging for people to identify what makes one group of patients or a set of subacute patients at higher risk than other patients. And that really made me start to want to sort of explore with the teams more about that, and what are the triggers, and I was really eager to understand the reason for falls, etc. So that sort of started me on the journey into the division. And just for context, that this program that I'm going to talk about today is an interdisciplinary program, a falls reduction program that we've implemented across 3 of our inpatient rehabilitation units, which is a total of 75 beds in a tertiary hospital here in South Australia, and it's at Flinders Medical Centre, and we also have a service down at the Repat Health Precinct. And this journey really started for us, or for me and the team, around this particular falls prevention program in 2017, and it still progresses today as one of our fundamental falls prevention programs, and it's called the Profits program. And you'll see as we go through that there is the theme of pink that comes through as one of our identifiers, and we came up with Profits around prevention of falls interventions for stroke patients. And I'll move through in some more detail around the program. So I have just referred to the background, that we are a division of rehabilitation, aged and palliative care with 75 rehab patients, rehabilitation inpatient beds. We have stroke, amputees, orthopedics, functional decline, haematology, oncology, and various different patients coming through. In 2017, we did have an increase in falls that was noted through our safety learning system, and that's when we were previously at the Repat Hospital, that you can see the picture there. And then we moved to a new beautiful building This is just one side of it here at Flinders Medical Centre. And we still saw, unfortunately, a rise in falls in 2018. And it was really concerning for us as a group of clinicians around why were our patients falling, why was there a rise. And so we did take it upon ourselves to do some auditing and really had a look at what kind of patients were falling at the time, and really did a bit of a deep dive into the data. And we can see from these audit results that we've got here that we undertook locally in 2017 and again in 2018, that we did have a significant, or what looked like a rise in falls per occupied bed days. And that started to make us really think about what was happening and why. So we pulled together a team of clinicians to start to engage in why were patients falling and what were the common themes that we could see in the data that we had presented to us. So we could see that, and we referred to, or if I just go back, sorry, we did start to categorise the patients into different groups, and we looked at what were the common diagnostic groups for patients, were patients falling, were witnessed, unwitnessed, what were they doing at the time of the falls, etc. And we did look at one of the articles that, or actually one piece of work and resource from October 2016 that was provided to us around patient falls, a systematic approach from the Joint Commission for Transforming Healthcare project. And we used the concept in there about trying to categorise the falls to create some themes. And then we also saw the recent article, the article at that time from Anne-Marie Hill in WA about falls rates in hospital rehabilitation units and how staff education programs, etc., did decrease the rates of falls, and how that were many multifactorial interventions. So what we did was we pulled the team together, we undertook some voting to really get local workforce engagement to try and make some change. We did identify in the data that we were looking at, that was presented to us, a common theme that the falls were occurring in stroke patients. And two of the areas that we saw was they were a stroke and they had a fall in the previous 12 months. And we felt that was one high risk group. And then the other group that we identified were those also that had a stroke and they had an inpatient fall pre-admission to us into subacute services. And that fall was usually happening in the acute services prior to their arrival in subacute. So with our lead intervention team, we went on and we implemented a multi-component falls prevention strategy program, including the profane categories of social environment and signalling aids, which were targeted at professional and non-professional staff, patients and families. The program was introduced for that high-risk cohort group that I've mentioned, that was identified on the previous slide from 2018, in addition to the standard falls prevention strategies that we already had in place in our clinical settings. The lead intervention team consisted of nursing, allied health, rehab physician and a patient and family rep. And I have to say, in our lead intervention team, what was the most powerful for us was having a patient and family rep and being the consumer voice. And I think also having executive sponsorship and support from executive, and also having a rehab consultant on the team was pivotal. And you'll see that pink was the chosen colour by the team at the time. I've talked about the program being the profits program. So we did very early on through the consumer voice, through Diana Voss, our patient family rep, we realised that profits was not the right terminology when we were talking about falls prevention in front of our consumers and their families. It was okay for us as clinicians, but actually we needed to call it a different program. So we turned it into the Call Don't Fall program when we were having a dialogue with our patients and their families. And I think that's a very good learning for everyone around how what we think as clinicians might make sense to us. The message can be very different to our consumers. In terms of the resources that we used to sort of launch into this program very, very early on, the intervention team created many resources, and that we realised also very early on that we needed to target education and knowledge for different disciplines. So what we had for information about the Profits program for clinicians, doctors, nurses, was going to be very different to the admin staff and also the patient service attendants, or what other people might refer to as orderlies. So we did have to do some very different types of information. So this is just a snip of what we were providing to the patient service attendants, the orderlies, to what we were showing to the clinicians, and to what we were showing to the general staff in terms of our communication very early on. So knowledge was a really important way, and targeting knowledge to different patient groups was really important before we started to launch into the program. As part of this intervention, so we identified the high-risk groups, which is the stroke plus an inpatient fall in the previous 12 months, or a stroke and a fall in this current admission. So what happened in terms of, we did some service model changing. So this is all in addition to our normal processes. We did screening on admission to the ward. So the team leader would screen in conjunction with the doctor and the allied health around did that patient fulfill the criteria around a stroke patient plus a fall in the previous 12 months. This was reiterated at the daily morning huddle, and also we and the team developed a very structured profit submission note that went through a key checklist, and we'll go through in a minute what some of those items were. And also it was flagged on the journey board, and you can see that starting to come up now are some of our pink identifiers, where people really, as in terms of the clinicians, really could see that pink was a clear identifier about a patient fulfilling a profits criteria. Some of the key interventions that we put in very early on was some signalling aids. So obviously the pink cues are coming up again. So one of them was the wristband. So that was in addition to their ID band. We developed a Call Don't Fall poster. Now this poster was designed with our patient and family rep, with patients and families. I think we came up with about 10 different versions. This was the final version that spoke very clearly to the patients. So when they went to the bathroom, it was located in several areas where the patient went to turn the light on, to where they sat on the toilet, they could see the signage. And it was also discussed with family and the substitute decision maker, or whoever that person was visiting the patient, because they're often very engaged when the patient is in therapy and wanting to keep them safe as well. So the Call Don't Fall sign with a big hand stop, and also those two photos in terms of the call bells are the actual real call bell photos that we have in the wards. So it did speak very clearly to the patients and their families. And we also had a Call Don't Fall poster, and we still do, on the doors to the patients' rooms, one that speaks to the family and carers, and one that speaks to the staff as another alert. These are some more of the other signalling aids that we've we have implemented. So the top left one here is flagging tape. It took me a long time to find where to find that, but we got that eventually. So it just rips off and ties off nicely, because we had to think about infection control and how do you easily remove that from therapy and mobility aids. So a patient would come in when they were and are identified as a high-risk stroke plus a fall in the previous 12 months, and if they're needing to use a wheelchair, they have a pink sign that goes on the back of their wheelchair that identifies that that identifies that they are a Call Don't Fall patient. On their mobility aid goes the flagging tape is tied on, and also we've got pink stickers there that went onto the handover sheets as well. Very early on, consumer information was pivotal in in implementing this program, in terms of engaging the family, their carers and visitors. And we also had our consumer rep who would sit with the patients and families, and she still does, around providing them with information about what we were then calling the profit. So you can see this is our first iteration of a consumer information brochure that actually didn't mean anything to the consumers, and it was a big no. So we moved to the Call Don't Fall program brochure, and this is the handout that we now give to our patients and their families around the program to really engage families in falls prevention while the patients are with us. One of the other interventions that we did put in place, and one of the key ones, and this is, some people might think, well, don't you just do that all the time? But I think the big target here for us was this intervention was not just targeted at nursing staff. This was targeted at all staff. So every time an admin person, every time an allied health person, every time a doctor, or every time a patient service attendant or orderly had contact with the patient or returned them back to their room after therapy, there were some key things that we really want each and every person to say to that patient and ensure the call bell's in reach, their water or their drink is in reach, and does the patient or client need the bathroom? And that was a big discussion there. So we had a lot of discussion around allied health, and PSAs would say, well, that's not our role to take the patient to the bathroom, and no, it's not. So they had triggers around, they would press the button, the call bell, to alert the nurse if the patient did need the bathroom at the time, and they would wait with the patient until the nurse arrived. Because we know from looking at our data previously that a lot of the falls were happening while the patients were wanting to go to the toilet. So this was a key intervention for us. Look, some of the other things that we've implemented around strategy for service model change is, and still continues, with weekly meetings and consumer rep input. Reviewing falls, we undertook a staff survey to understand the perspective from the staff. Did they understand actually what the falls prevention program was about, and did they understand what all the interventions were about? Consumer feedback and stories was pivotal to us during the interventions, and also continues now. We regularly do reports, and all disciplines currently have full orientation and get regular updates about the profits program. Consumer feedback has been pivotal to us. So these are just some of the quotes that we've received from patients and families. Some of it is very positive, and some of it gave us some learnings around mum doesn't speak English, or the posters didn't make any sense. So we had to look at different languages. This is the data the data analysis that has been undertaken recently, and this slide demonstrates the interrupted time series analysis of all rehabilitation inpatient falls, and which was reviewed to ensure the increased focus on the high-risk group had not inadvertently increased falls elsewhere. And this graph demonstrates the total fall rates across the 3 wards, and you can see where the intervention was put in August 2018, and this data analysis goes up right, and the interrupted time series analysis goes up to October 2019. There are 2 phases to our program. We're currently in phase 2 because we've had a bit of a service design halfway during or in January 2019, where we changed the cohort of patients where we had a dedicated stroke ward. So we're still to undertake some further analysis in these areas where we want to have a look at the integrated time series comparing pre-intervention versus phase 1 and phase 2, where we've got the dedicated stroke ward now, and where the split happened in January 2019. So we did have a bit of, like I said, a service model change, and we still want to examine falls audit that instigate the profits program, adjusting the patient diagnostic profiles profiles as well in the pre-intervention stage. So we still haven't got all of our data analysis back, but this is the beginning of some of the, you can see it has had statistics that falls were significantly reduced. One of the important parts, just to quickly refer to, is around sustainability, because that's often a big challenge for all of us. And we did have to do a bit of a reset last year into things. We did have a couple of significant falls, and we did identify, unfortunately, that one patient was not screened appropriately and not identified as a calls don't fall or profits patient. So we've done a bit of a reset and a relaunch in the last 6 months. So it's really important to keep on going with check-ins, meet regularly, review the resources, keep programs on the quality and safety agenda so it doesn't fall off. Feedback to staff and having executive support has been fundamental to the success of this program. And really, I mean, in summary, safety is the responsibility of each and every one of us. This team approach, inclusive of patients and families, has imparted significant service-wide in falls reduction in some of that data that I was able to show. And falls reduction does have a personal impact on each and every patient and family, and a service benefit in terms of cost and reputation as a consumer-focused institution. So thank you very much. And I did want to just quickly thank some of the team, particularly Zoe, Diana Voss and Suzanne Dyer for their support in this program. I'm happy to
thanks very much, Petra. I think, again, we'll hold our questions to the end. Hopefully we'll have 10 minutes at the end for some questions, but on the early data, that certainly looks like a promising program, so it'll be good to see how that develops. Our next speaker is Associate Professor Frances Batchelor. She's a Principal Research Fellow and Director of the Clinical Gerontology Division of the National Ageing Research Institute, and also Research Lead in the Melbourne Ageing Research Collaboration. And she's a clinical and research physiotherapist. So perhaps we'll go to Frances.
Thanks, Sue. Thanks, Sue. I'll just share my screen. Let's see if that's going to work. Can you all see that?
Yes.
Good, excellent. Well, good afternoon, everyone, and thank you very much to the CRE for inviting me to present at this seminar. Today, I'm going to talk to you about a very grassroots approach to falls prevention in hospitals, but one I think that has its basis in data and implementation science. We've had a very good introduction from Sue, and also there are many things, Petra, in your presentation that resonate with some of the work I'm going to talk about today. Obviously, we know falls are a big problem for hospitals, and they're associated with lots of bad outcomes, and they're also, as Sue pointed out, costly to health services, but also individuals. But on a very practical level, we see that there's some evidence about what works to prevent falls, particularly in subacute settings. But if you work in an acute setting, that evidence is not always transferable. There's issues around whose roles and responsibilities falls prevention is. Many strategies are implemented and they're not always evidence-based. So things like alarms and so on, there's lots of new products coming onto the market. And there's often a push within health services that we must do more because perhaps we've had a spike in falls and we really need to do something and implement additional things, but we can't just keep adding on strategies. And there may be some side effects of falls prevention strategies. So if you're keeping people less mobile, obviously mobility declines and perhaps the risk of falls increases. So I guess the question is really, what should health services do? Falls seem to be resistant to interventions. You implement something, you get a temporary reduction in falls rates, and then you can see sometimes that it creeps up again. So to try and answer this question, we used a data-driven co-design approach in 2 projects, and I'll just be talking about one project today. And I'll get to the data-driven aspect shortly. But firstly, what is co-design? I'm drawing on some work here done by a PhD student at NARI, Ellen Gaffey, who's undertaking a PhD looking at co-design with people living with dementia. So traditional approaches to research in health have generally been investigator-driven or expert-led, but increasingly we're recognising the importance of real involvement of all stakeholders. So that means when we're talking in co-design language, that might mean frontline staff, allied health professionals, nursing staff, medical staff, but also the involvement of patients and their family or informal carers. So co-design is one such approach, and it's increasing in popularity. There's a lot of buzzwords around, and it's easy, I guess, to become lost in this new landscape of design. And there's also lots of overlap. But I guess the key thing that differentiates co-design from other methods is engaging with people. So you can see that we've got in the orange, there's co-production and co-design, and really that focuses on activities, and in this case, research or a project to reduce falls that is involved in doing with those, the important stakeholders. Whereas traditionally, I guess, as I said, it's been expert-led research with an idea based often in, very sensible, grounded approach, but very much driven by a researcher or expert. And I've been involved, obviously, in that kind of research too. But one thing to note is that co-design is not just about doing what people think is the right thing to do. So it's not just, I think it might be a good idea to implement X. It's informed by in-depth understanding of the issue at hand. And in the case of falls, informed by data. So what is the process? And here I've used some slides from Ellen as well. A typical co-design process, and here I've got the picture of this so-called double diamond approach. Co-design generally involves 4 distinct stages, but these can be iterative. But there are other co-design methodologies out there, and some of those are very similar with some minor differences, and some might be quite different. But here what we see, we have a general problem. The first stage is to really empathise or to understand what the particular issue is from the perspectives of different stakeholders. Further define the problem. So at the start you go very broad, but then you narrow it down to a more detailed problem that you want to address. The third stage is then the idea generation stage, where you look at potential solutions for a particular problem. And again, the idea here is to go broad and then refine that down to a prototype and test and evaluate until you come up with a solution. And as I said, these can be very iterative processes. So within the project, what does this look like in the context of health services interventions? So it goes back to the double diamond idea that I showed on the previous slide, but we have these 2 broad elements of exploring the problem and generating solutions. And so we want to have, an insight into a consumer problem, or in this case, a ward-based problem, observe whether problems exist and defining the area to focus on, and then generating possible solutions and testing those solutions. And these 4 colours, I'll take you through those when we talk about the project and what we did. So this project was undertaken as part of the Melbourne Ageing Research Collaboration, which is a program or a platform of work led by NARI. But importantly, it includes health services who identify the problems most relevant to them. And 2 of the hospitals with partners within the MARC program of work identified high rates of falls in particular wards. And they had similar questions. We've tried everything. We've had falls blitzes, falls champions. We have a falls dashboard, but falls rates continue to be high. What can we do? And these are the 2 wards. So one ward, the ward on the left, is an acute unit, so we're within an acute public hospital, but obviously has a very high proportion of older people. And on the right, it is a ward located in a subacute hospital, but focuses on acute care of the elderly. So in a sense, 2 different locations, but some similarities across both of the wards with a similar patient age profile and similar issues. So on the surface, they look the same. So obviously in the first stage understanding, we already had an understanding of the problem and what the overall objective was. So that was fairly clear. We didn't need to spend too much time looking at that. But in the next phase, we needed to define exactly what the problem is. And similar to what Petra talked about, we looked at ward profile data, work practice information, and we wanted to gain a detailed understanding of the falls and faller profiles, as well as the staff survey, a survey about knowledge and perceptions, and from the perspectives of patients as well. And for us, as I said, it meant just not focusing on just the patient elements. We really needed to consider hospitals as complex adaptive systems. So we needed to look at those elements around staff, the environment, and the clinical and organisational systems. And this just gives you an idea of the type of data that we collected. So our aim was to reduce falls. We looked at over a 10-week period, every fall that happened, and collected in-depth information about the fall. So not just time, but particulars about the patient, their cognition, their behaviour, also about things like, had the nurse been in the ward, for example, on rounding shortly before. And as mentioned, we collected a whole lot of other information. So staff opinions is not quite the right word, but it's knowledge and attitudes and experience, as well as the patients. And interestingly, to leap ahead to a result, the patients predominantly felt that in hospital they were safe because the nurse's job was to keep them safe, which, as we know about falls rates, the nurses do a fantastic job, but hospitals are kind of inherently, places with some risk. So what did that look like? So the detailed falls data collection revealed some interesting things at each of the sites. So at site 1, we indeed had a very high falls rate of 14.2 per 1,000 bed days, and site 2 slightly lower at 12.9 per 1,000 bed days. At both sites, 30 to 40% resulted in injury. At site 1, falls predominantly happened during the day, whereas site 2, overnight. Site 1, most falls, or nearly half of the falls, happened when patients were walking or standing up, whereas at site 2, 3/4 were falls from a bed or chair. And a key difference was that only a third of the patients who fell at site 1 had impaired cognition, whereas that was much higher at site 2. So a key the next phase in terms of the co-design process is then feeding that data back to the organisation and assisting them to identify priorities and then select the strategies for implementation. So the key issues we had at site 1 were the patient perceptions of falls, staff availability, falls from standing or walking, and the likelihood of risky behaviour. So patients thought that they were independent or capable of being independent, so, mobilised on their own. And cognition wasn't so much of an issue. Whereas at site 2, they were happening in evenings and overnight, falling from bed or from chair, and there were issues around cognitive impairment. So you can see that things that have shown to be effective, for example, in subacute, such as multifactorial interventions that focus predominantly or a large amount on education, are not going to work for the types of patients who were falling at site 2. So after we have been through the process of defining the problem, understanding and coming up with ideas about potential causes, then it was up to the staff to decide the strategies that they wanted to implement. And so at site 1, I didn't talk about the environmental audit, but every single bed had a high falls risk sign. And I guess if everyone's at risk of falls, maybe you don't need those signs. So they decided that it was visual clutter that was not very meaningful to patients or staff. And so they removed that. And the second strategy they chose was really focusing on assessing patient behaviour, that is the likelihood that a patient would stand up and walk when they needed supervision, and educating patients about the need to call, so similar to what Petra was talking about. And then they implemented those strategies through a variety of training and as part of routine care. Whereas at Site 2, what they decided was that patients required constant supervision, especially the high-risk patients. They needed to involve all staff in falls prevention. So again, similar, Petra, to what you were talking about. And so what they did was created a no fall zone, which was the 4-bed bay with the patients at highest risk of falls grouped together so that nursing staff could be in there the whole time. And then encouraging incidental intervention. So yeah, similar to Petra, asking anyone who was walking past a patient who was trying to stand up, for example, what they might need. And they implemented those by developing a tool for deciding the no fall zone and then educating all staff. And that just represents all the stages of the co-design process. And so what was the result? So at Site 1, we saw that falls reduced from 14.2 per 1,000 bed days to 4.5, and at Site 2 from 12.9 to 4.5 falls per 1,000 bed days. So in terms of result, that's very promising, but with any of this type of intervention, we need to look at process. So what is the process? What were the implementation strategies implemented as planned? And I'm not going to go through all of these in detail, but just to point you to the fact that at Site 1, they had a very high rate of implementation of the processes as decided, and they recorded a lot of detailed information about doing exactly what they said they were going to do. So I guess the adherence to strategy implementation was extremely high. We can't really say the same thing for Site 2, just as it turned out, and this is pragmatic research in real world settings. They had an outbreak of gastro. It ended up being over the Christmas period. They had a lot of bed closures, and obviously with the gastro outbreak, they couldn't actually group the patients most at risk of falls together, obviously because of infection control procedures. So ideally, in the ideal world, we would be able to say there was good adherence to the intervention strategies at Site 2, but the reality is that wasn't the case. Nonetheless, we did see that reduction in falls, so that is potentially perhaps seeing the increased awareness about falls leading to that. And just, it's also important to look at whether the intervention, I guess, reached the intended targets, if you like. So at Site 1, it was more the mobile, less cognitively impaired patients. And at Site 2, generally less mobile patients with some cognitive impairment, whether that was delirium or dementia. And so what this graph shows is the before and after profile of the falls characteristics. And what we're looking at, so we have the solid bar is the pre-intervention characteristic, whereas the hashed bar is post-intervention. And what we're looking for is a change in profile. And I haven't included all the different aspects. This one just looks at the time. And so we see at Site 1, the profile of when people fell changed from not being so much in the evening to an increase in falls in the evening. And I think this is one reason why we see falls rates not coming down, is because they tend to be kind of slippery and resistant to change. So if you address one aspect of falls prevention, then perhaps, you know, another aspect then needs a focus. And I think one thing we've learned from this, it needs to be an ongoing iterative process of examining data and then responding and evolving the intervention. So you're not just adding strategies on, but you're responding to the profile, the mix at a particular time. And just in some of, in Site 2, so the falls that happened overnight pre the intervention did reduce the proportion of falls then that happened overnight. We saw that there was a very, very few number of falls percentage-wise at Site 1 happening on the day of admission, but that increased. And so the next phase would have to focus on that early admission phase to target. And then we just had some interesting findings. So English preferred language obviously was people who were the target of the education intervention, the patients in the pre-phase, but obviously that dropped down into the post-phase. So I think, as well as looking at what the outcome is, we need to carefully examine those process factors to determine, yes, the fidelity of the approach and adherence to the implementation strategies, as well as whether we are actually making a difference to that target profile or population, if you like. And I just wanted to conclude by acknowledging that this is work undertaken, as I mentioned, as part of the Melbourne Ageing Research Collaboration, which has a number of partners. And I haven't talked about the second project today, but in terms of the first project, obviously a number of wonderful team members who have made that pilot project possible. And I might finish there.
Okay, thanks so much, Frances. I think that was two really interesting talks, and I think we can see some interesting commonalities there too. You've clearly both looked at the data in your hospital settings, looking at, you know, which groups the falls are occurring in, and really tried to target that. But importantly, both involved consumers, and all of the staff. Seems to be a real wraparound approach that you've both taken, which is interesting. We've got time for a few quick questions if people want to send them through on the chat, or I'm not great with this. Is there a hand raising type mechanism? Well, perhaps while we're waiting for that to come through, we've touched on this, and I know that you mentioned a bit, Frances, but perhaps to both of you, we know that cognition is definitely a problem, people with cognitive impairment. Did you involve patients and families of those with cognitive impairment in your approaches, in your co-design or implementation, both of you?
Is that
sorry, yeah, either. Perhaps Petra?
So our cohort did have a mixture of patients with cognitive impairment or changed behaviours and not changed behaviours. So definitely in ours, and we have a lot of, I mean, we still had falls in our profits patients, and we are still monitoring around and collecting that data around cognition. And is it happening more frequently in those groups? What does that look like with outcomes, etc.? But engagement with family or the substitute decision maker, and if they can help in minimising falls while they're in patients, it has been pivotal for us.
Okay, Frances, did you?
Yeah, so we had a community advisory group member on the overall project team, but we didn't specifically involve family members of patients with cognitive impairment in this particular pilot. And if I was to do it again, we'd definitely do that. So it was probably one thing we'd change.
Okay, thank you. Terry Haynes has a question.
Yeah, thanks, Suzanne. Thank you both for the presentations, Petra and Frances. I was wondering, for your projects, were you able to capture any data on how much direct patient education about falls was taking place, or how many times the frequency with which staff members would talk directly to patients about their risk of falls? Did you have any data on the frequency of those sort of discussions?
Maybe if I ask first, so we haven't been capturing that in terms of, I think your question is how many times were nurses or clinicians telling up how many times they had that interaction, and it was targeted at education. So in a 24-hour period, was it once or was it twice or was it zero? So we haven't been capturing that, but we could we would be able to say that everyone was receiving that information on admission. And then again, I do know that the nurse unit manager, and that's been in the targeted stroke ward, does have specific conversations again with the patients and their families to check in. But we're not actually monitoring how many times have we been undertaking that. Do you think that's worthwhile?
In the work that we've done, and for example, with Anne-Marie Hill's paper cited earlier in your presentation, Petra, the one-to-one patient education is what takes a lot of time. And I guess if you're thinking about the cost effectiveness of the program, this is what I've wrestled with over the years, is that one-to-one education seems to be quite strong in its effect, but it's also time consuming and resource intensive. So trying to get a handle on how many minutes are being contributed to that effort, and is that maintained over time, after the initial program is launched, or is that something that dies off after time? I think that it's interesting to understand how that operates in the context of projects like the ones you've been running.
Yeah, and we definitely know that and moving forward is we want to do some different types of targeted educations around videos targeted at patients around how to minimise their risk of falls as inpatients, in particular patient groups. So yeah.
Thanks, Frances.
I was going to say, I think it's a really good point with any types of strategies that implemented, because you see kind of that behaviour change with the staff, that they, there's a spike in the efforts that they're making, and then that can tail off. So capturing that would be really important. One thing, we didn't capture that data specifically, but we did survey the patients on a number of aspects. And a lot of them, we asked them, could they name any falls prevention strategies? There was overall, we did this as a kind of point prevalence in one of the hospitals, just because we were getting some surprising results. And, the majority of patients could not name falls prevention strategies. So whether or not they were getting education, it wasn't seeming to translate into their understanding of what they could do. And they were saying things that align with work that you've done, Terry, about, it's not a problem for me, but Mr. Smith over there, he's really at risk of falls and should do something about it.
Yeah.
Okay, thank you both.
We've got a question that's come through from Sandra Lever. Frances, are you able to share the criteria for the falls safe zone, please?
Great question. I haven't got it right here. I'd have to go and have a look at what the staff came up with, and it was based on the priority that they put on that patient. So it was more of a clinical decision, and it was probably one aspect, again, as I mentioned, fell down a little bit within that site just because of what happened with their gastro outbreak. And so it started off well, and they were well on their way to getting that no fall zone established, and then that tapered off as well. But I can follow up, Sandra, if you'd like.
Okay. There's a comment here, I think, from a small nursing home grad project conducted at a large private hospital in Perth last year. Patients surveyed indicated their preference was for 1:1 patient education with nursing staff. So I think that's a comment that relates to your question, Terry. Okay. If we've got one more question, if there's time, or if not, we might wrap it up.
Sue, I think Vazi's got a question.
Can I throw in? This is a big question. Sorry, Susan. This is to almost tie the beginning of the talk and the end together. It's sort of where from here, right? Because, do you think you need more high quality evidence in terms of design, i.e. randomized trials, step wedge design, or do you need more almost the before and after in sort of the quality improvement type methodology, which Frances showed? And, hospitals, the falls in hospital, that's the real, in a way, I think that's the dilemma, right? High quality evidence versus, and you maybe versus is the wrong word, or versus sort of this really, wouldn't it be fair to say, Frances? I mean, this is a classic, really great quality improvement type project, right? That showed really nicely, right? The effect.
Thanks, Fuzzy. Look, that's a really good question. I believe strongly that we need to evaluate this in a robust trial in a step wedge design. And the reason that I think it can appear as a quality improvement project and it can be undertaken like that is because of, you look at factors and then you do something to address those factors. But where we need to have fidelity is around the approach, and to make sure that we validate this as an approach, not just, the individual factors that are implemented, but the overall approach of that co-design, data-driven development and application of strategies, and seeing if they have an impact, that same approach across multiple different sites of different hospital types. Because what we've seen now is that a one-size-fits-all approach doesn't work if you just select the strategy. So, high-quality study, step wedge that takes into consideration those pragmatic aspects, but also recognises that hospitals are complex adaptive systems.
Okay, thanks very much, everyone. I think we're out of time, but thank you very much, Petra and Frances, for your talks today. I think hopefully very informative for everyone working in hospitals trying to undertake falls prevention strategies. Thank you very much.
Thank you.